Hello and welcome to the respiratory acute section of pharmacology. In this lecture we're going to go over allergy, cough and cold, viral upper respiratory infection, sinusitis, influenza, and pneumonia. The good majority of what we'll be talking about is a lot of supportive care. As we've discussed previously, there is no real treatment for viral infections, but really taking care of our patients with the supportive care that they need. So first we're going to talk about allergy. Antihistamines are H1 antagonists. We previously have talked about H2 antagonists when dealing with the GI. This is the histamine 1 receptor. There's two generations, the first generation and the second generation. The first generation are things like we are familiar with, like diphenhydramine or Benadryl. They have a lot of anticholinergic effects, can be very sedative, and are active for about 4 to 6 hours. The more newer generation, the second generation, is more selective for the peripheral receptors. They don't cross the blood-brain barrier, and they're active for 12 hours or longer. So a much better treatment option for our patients dealing with allergy signs and symptoms, less sedation, longer acting. Overall, typically a better product. We use antihistamines to treat a variety of acute respiratory symptoms: sneezing, rhinorrhea, watery eyes, itching. The good majority of these are available over the counter at this point. Items such as loratadine or Claritin are very commonly used over the counter. So as you review the material in the textbook, please keep in mind that some of those that may be listed as prescription products may have changed to over-the-counter. Again, fexofenadine, loratadine, some of the more common second-generation antihistamines. Another product we have in our arsenal for treating allergy symptoms is a steroid nasal spray. Steroid nasal sprays are specifically used for allergic rhinitis. They're not for the symptoms of the common cold, so I'll make some point of clarification there. They're more specific for allergic rhinitis, not for typical common cold. These drugs are delivered locally, so there's a potential for nasal irritation, dryness, and even potentially epistaxis. The nice thing about these is they don't get well absorbed systemically. They really treat the site of action. These products include items such as fluticasone and mometasone. Fluticasone or Flonase is now available generically and is relatively inexpensive, even for those patients who don't have insurance. Viral upper respiratory infections, or the common cold, it's a non-bacterial infection of the upper respiratory system. And actually the reason why these slides are a little delayed, I was recently battling a common cold, which made my voice very terrible and not enjoyable to listen to on a recording. And I'm sure many of you are battling with the same symptoms this time of year. The rhinovirus is the most common virus. You will also see some other viruses causing these upper respiratory infections. Again, the big thing to remember is they are viral and there is no need for an antibiotic. That is a really big thing that patients don't always understand. They think that when they're sick they should have an antibiotic, but as we know as practitioners, when something's caused by a virus, an antibiotic isn't going to do anything, and we're actually going to increase resistance. Children get 6 to 8 colds a year, more if they're in daycare. Obviously there's more opportunity for transmission. Adults average 2.5, so 2 to 3 colds per year. Some symptoms more severe than others. Typically it lasts about 7 to 9 days. When your patients have a significant runny nose and cough on days 1 to 4, so the first couple of days, it really is more predictive for a viral origin. And in this case, we are certainly not going to be giving any antibiotics. Again, supportive care, recommending antihistamines are certainly a viable option. The steroid nasal spray, again, not a good option for the common cold. Those are more for allergic rhinitis. So if your patient does have allergic rhinitis in conjunction with a cold, a steroid nasal spray is okay. Just because they have a cold doesn't mean that the steroid nasal spray is contraindicated. Just want to make that distinction. I'm sure we're all familiar with the usual symptoms: nasal congestion, rhinorrhea, malaise, scratchy sore throat. Nasal discharge usually starts out thin and clear, so that really runny nose, and then thickens and progresses to a green or yellow color. There's potential for generalized muscle aches. Adults typically don't have a fever. With an upper respiratory infection, children may have a low-grade fever, so just keep that in mind. If an adult has a fever, there might be something else. There might be something more going on. So some of the treatments for cough and cold, we talked about patients be congested, so decongestants are a symptomatic relief. Alpha adrenergic receptor antagonists, or sympathomimetics, cause vasoconstriction, which reduces the mucous membrane swelling, which helps relieve some of that pressure and congestion. There's a couple of different products out there. Phenylephrine is safer than the pseudoephedrine. Pseudoephedrine has potential cardiac side effects, and also in the recent years with FDA and federal regulation, pseudoephedrine is a little more challenging to come by. That's when you have to go to the counter, give your license. Some think that it is a little more effective than phenylephrine. That's all more personal preference, but again, the phenylephrine is certainly safer, particularly in your patients that do have cardiac issues already. The pseudoephedrine can cause increased heart rate. There's also oral and nasal. Again, nasal would be more topical, less systemic involvement, less risk of side effects. The key point with the decongestants, there's a phenomenon called rebound. If a patient takes decongestants such as pseudoephedrine, phenylephrine for several days straight, around the clock, there's a potential for what's called rebound congestion. That's when they get actually even more congestion than when they started with, and there's going to be no drug that's going to help them. It's a physiologic effect, so it's very important to talk to your patients if you are talking to them about upper respiratory infection and recommending a decongestant. Make sure they use it for just a very short time, just a couple of days. Anything longer than 3 to 5 days, you do run the risk of potentiating rebound congestion. So a couple of examples. We already talked about the pseudoephedrine and the phenylephrine. Again, available over the counter, wide variety of dosage. There's an immediate release, and there's some suspended release products that patients will take once to twice a day rather than 3 to 4 times a day. I've also mentioned the topical decongestant. So phenylephrine is available topically. That's the neosynephrine, and there's also oxymetazoline or Afrin. I think we're probably all familiar with these over-the-counter products. Again, the important thing to stress is the risk of rebound congestion. We certainly don't want our patients taking these for longer than 3 or 4 days. Otherwise, they do run that risk. The oral decongestants, again, they cause vasoconstriction of the capillary vesicles, theoretically decreasing congestion. Some of the ADRs, particularly with pseudoephedrine, is tachycardia, hypertension, anxiety, restlessness, and irritability. So when we're talking about symptomatic care, we've talked about the decongestants. We also want to make sure that patients have plenty of fluids on board. They could become dehydrated, particularly when they become congested and they start breathing through their mouth. A lot easier to get dehydrated. Antipyretics, as I mentioned, in children, they could have a low-grade fever and might warrant some acetaminophen or ibuprofen. You could do some nasal bulb suctioning in infants. Obviously, they're not able to blow their own nose and clear some of that mucus. And then decongestants in the older children and adults. You want to avoid decongestants in young children and infants. And again, I don't think I can stress this enough. No antibiotics. There's no difference in clinical outcomes. If the patient has a viral infection, an antibiotic is not going to do anything. Again, no evidence for the efficacy of systemic decongestants in the treatment of upper respiratory infection in children. And this actually may even be hazardous. In 2004 to 2005, over 1,500 children aged less than 2 were treated in U.S. emergency departments for adverse events from cough and cold medications. There's even been some deaths in infants and young children. Some of this is adverse effect of the drug, and some of this is parents not knowing how to appropriately dose these medications because they are not intended for children. so they end up with an overdose. Really, again, I can't stress it enough. Infants and young children should not be using any kind of systemic decongestants. So, talking about the cough part of the cough and cold, we have antitussives and expectorants, and oftentimes they're given in combination. So for antitussives, we have dextromethorphan, which is available over the counter, codeine, which you know as a pain med, but it also inhibits the cough center in the brain, and benzonatate, which is anesthetic, so it literally numbs and paralyzes the throat so that the patient doesn't cough as much or as hard. And expectorant, guaifenesin, so that basically just helps thin and get rid of mucus that the patient has. So if the patient has thick mucus and they're coughing and they can't get rid of it, so productive cough, a product with guaifenesin is an excellent choice. It helps thin that mucus and it helps when the patient does cough to remove some of that mucus from the respiratory tract. So dextromethorphan and codeine act centrally acting cough suppressant. Dextromethorphan is actually an analog of the morphine molecule. It takes away all of the analgesic effect. It has no effect on the pain receptors, but it does still have that cough center suppressant. As far as what's better, codeine is no more effective than dextromethorphan or placebo. It tends to have little efficacy in cough due to upper respiratory infection because the cough isn't derived from the cough center. It's really literally irritation. Of note, some people are poor dextromethorphan metabolizers. That's not something that you're going to test for or know about, but just know that if dextromethorphan is not working well in your patient, that there is such thing as being a poor metabolizer. And when we talk about antidepressants and mental health later on, this is an important drug-drug interaction. Dextromethorphan and antidepressants may lead to serotonin syndrome. And there is, believe it or not, potential for abuse. So even though there's no effect on the pain receptors, there's none of that euphoria with dextromethorphan, when taken in large enough quantities, it can cause patients to hallucinate. A couple years back, it was high school kids that were drinking large quantities of dextromethorphan. They were calling it robo-tripping. Robitussin's a brand name for a product. That's the other distinction too. There's a lot of cough and cold combination products out there. Make sure you and your patients are reading the labels to know exactly what's in them. If the product just says Robitussin, typically that's just straight guaifenesin, just a straight expectorant. They're going to have no cough suppressant effect in that. The Robitussin DM is the product that contains the dextromethorphan. So typically when you see DM on a product, the DM is indicating dextromethorphan. So as I mentioned, expectorants, guaifenesin or Robitussin's a brand name, stimulates respiratory tract secretions, decreasing the viscosity. Really the important thing to remember when patients are taking expectorants, they need to drink plenty of fluids, because if they're dehydrated, there's going to be nothing to decrease the viscosity of the secretions, so the drug really won't have any effect. It really needs plenty of fluid to work. And no evidence for efficacy in chronic cough or cough due to upper respiratory infection. So if a patient has a chronic cough, just straight guaifenesin is not going to help them with their cough. Again, it's intended to stimulate respiratory tract secretions, get the mucus out, help the patient get the mucus out of their system. As far as patient education, again, I mentioned make sure we read the labels, make sure the patients follow. Most of the stuff is over the counter. The reason why it's over the counter is because the FDA feels that patients are capable of looking at the labels and determining how to best take them for their own selves. But really the proper dosing of decongestants, and that, as I mentioned before, the rebound congestion, so really limiting the duration of use. We want to avoid decongestants in children, younger than 3 or 4 years old, elderly, or patients with cardiovascular disease. We also want to avoid decongestants. Symptoms typically resolve in 7 to 10 days, and again, antibiotics are not necessary. I cannot stress that enough, that antibiotics are absolutely not necessary in these conditions. So now we're going to switch gears a little bit and talk about acute bacterial rhinosinusitis. So the distinction here is bacterial versus viral sinusitis. Guidelines were recently updated about 2 years ago now. Clinical infectious disease, the references on the slide here, it is publicly available. I suggest that you pull those up and review the guidelines. Not necessary to memorize them, but certainly look at them and be familiar. Some of the common pathogens are listed here on the slide. So strep pneumo, H flu. Staphylococcus is rare in bacterial sinusitis, but it does occur. So antibiotic choices for sinusitis. So we had our lecture on infectious disease. Now we're kind of expand a little bit and go into more specific disease states. So amoxicillin with clavulanate is first line in children and adults. High dose, again, we don't need to know dosing, but just know that it is high dose in severe infection. Patients that are in daycare, those patients that are less than 2 or greater than 65 years old, we're going to want to go with a higher dose. And then recent hospitalization or antibiotic use in the last month. And the reason for that is these patients have a more likelihood of having a higher resistant organism or a more difficult to treat organism. Again, as we mentioned earlier, children that are in daycare have a lot more exposure, a lot more opportunity to share amongst their friends. And those less than 2 or greater than 65 have the decreased immune system response, and obviously hospitalization or antibiotic use could expose patients to resistant organisms. So not recommended for empiric therapy. Fluoroquinolones, trimethoprim sulfamethoxazole, and macrolides. Again, amoxicillin clavulanate is the first line. For those patients that are penicillin allergic and amoxicillin is contraindicated, doxycycline in adults or a respiratory fluoroquinolone. I know respiratory fluoroquinolones aren't highly recommended in children, but again, with limited options, the fluoroquinolone is safer than giving a patient something that they're allergic to. Then this is also something that we really should treat and cover. Routine coverage of Staph aureus or MRSA is not recommended in these conditions unless you know your patient has a prior history or some exposure. We really don't want to be routinely covering for Staph aureus. So the duration of treatment, this again is important in managing resistant bugs and really global health. We don't want to over-treat or treat for too long. We want to use the narrowest spectrum possible for the shortest duration possible. And the evidence shows that the duration for sinusitis in uncomplicated adults is 5 to 7 days and 10 to 14 days in children. There's some adjunctive therapy that we can also use, such as intranasal saline irrigation in adults, intranasal corticosteroids. Again, particularly in those patients with a history of allergic rhinitis, that's when the intranasal steroids are going to really work the best. Topical and oral decongestants aren't recommended in these patients. So if your patient's symptoms worsen after 2 or 3 days, or if there's no improvement in 3 to 5 days, you're going to refer to the algorithm contained in the guidelines from IDSA. This is when we're going to evaluate for possible resistant pathogens. We're also going to consider a non-infectious etiology or a structural abnormality. The patient may have some type of sinus cavity that's deformed or not normal, and at that point, that's when we would start looking at following the algorithm, using the second line treatment with the understanding that it might be non-infectious or a structural abnormality. If they're not improving or getting worse on the second line treatment, that's when we're going to want to seek a consult from a specialist. They're going to do some more invasive cultures. They can do some imaging studies to see if there is any structural abnormality. But again, we want to treat our patients following the guidelines. If they get worse in 2 or 3 days, or they don't improve in 3 to 5 days, escalate to second line treatment. And if that's still not failing, do not hesitate to seek consultation. And here's the algorithm from the guidelines. Again, the reference is at the bottom of the slide. Don't expect you to memorize the algorithm. Be familiar with it, understand it. Again, this may be something that appears as material on the test for you to work through. But I certainly want you to get a good grasp of it, review it, because it really is helpful in kind of thinking about how to treat your patient and following that logical progression. Next, we're going to change gears and talk a little about influenza. Influenza, as we know, is a virus. There are some antivirals available. Also, Tamiflu or Tamiflu is probably the most common There's also zanamivir or Valenza. They both treat influenza A or B. The sensitivities vary by year depending on which strain the patient's infected with and which strain is more active. Resistance to amantadine and rimantadine is common. Neither is recommended at this point. So really when we're talking about antivirals for influenza, oseltamivir and zanamivir are the two that we're going to think of. Oseltamivir is well absorbed after oral administration. It's also available in a suspension form if patients aren't able to swallow capsules. Zanamivir is inhaled, 4 to 17% absorbed. Again, oseltamivir is the more commonly used product. And the CDC updates the prescribing recommendations annually, so it's really important that at the beginning of the flu season, you just go check out cdc.gov/flu. It'll give you all the information that you need for the upcoming flu season, what they're predicting for strains and the severity and the timing of it, because don't forget, every area of the country is going to have a slightly different flu season depending on the climate, but every area of the country will indeed have a flu season, so it's important to keep up to date on the current recommendations. So if you do prescribe an antiviral for your patient, it's important that they take that full course of therapy. Even if they start feeling a little better, they still want to complete it. We don't want to have any residual infection. There's minimal ADRs, and really we want to again stress the annual influenza vaccination. Now again, it is possible that the patient does become infected with flu, even though they had the vaccination as we talked about previously. They may be infected with a different strain than what they were vaccinated with in the flu vaccine, because again, don't forget there's only 3 to 4 different strains included in there, or they may not have mounted a strong enough immune response to that vaccination for a variety of reasons. Again, the elderly don't mount as severe of a response, and they could potentially become infected, but even a younger patient just may not develop enough and could become infected. So even though your patient does get influenza, we still want to remind them it's important to get it every year. Try to explain to them that it is not a worthless product, that just because they did get infected does not mean that it should not be gotten every year. So now we're going to switch into pneumonia, still maintaining the upper respiratory tract here, some lower. So pneumonia develops when an organism invades the lung, particularly when the host defenses are depressed. Bacterial pneumonia can result when the primary defense mechanisms are altered, so a co-infection with a virus or immunological problems could potentially lead to bacterial pneumonia. Chronically ill patients of all ages are more prone to pneumonia. Again, it's when our natural defenses aren't strong enough to protect ourselves. So when we talk about treatment, we basically want to return to the baseline respiratory status, resolution of fever in 2 to 4 days. Leukocytosis resolves by day 4 of treatment. When you're treating on the outpatient basis, you may not have these labs. This is more when the patient's admitted acutely. Of note, the chest x-ray may take 4 weeks or more to return to normal, even though the patient's symptoms have resolved and they're fully functioning. There still may be chest x-ray changes for up to a month. So some of the common pathogens that we see strep pneumo. In those patients with underlying lung disease, they may have H. flu, Moraxella catarrhalis. Staph aureus is sometimes co-infected with influenza. Mycoplasma pneumonia is a possibility, and sometimes we do see viral pneumonia, but for the most part, we are dealing with bacterial pneumonia. Again, there's Infectious Disease Society of America and the American Thoracic Society came out with a consensus statement. It's a little old at this point, but it is still the most current available. So from 2007, and it breaks the patients down into basically 4 categories. Previously healthy, no risk factors for drug-resistant strep pneumo, patients with risk factors, patients not admitted to the ICU but admitted to the hospital, and then those patients that are admitted into the ICU. And there's different recommendations for treatment. We're going to focus on the the community acquired. We're not going to talk about healthcare acquired pneumonia at all in this class. So community acquired pneumonia, sometimes you'll see it spelled CAP or CAP. The adult patient with no risk factors, We're going to use a macrolide, level 1 evidence, so that's the highest level of evidence in the guideline. They recommend azithromycin or clarithromycin or erythromycin. Azithromycin is the go-to. It's the workhorse. It has the lowest amount of side effects compared with the other two, a little bit less drug-drug interactions. So really, when we think macrolide for pneumonia, we're thinking azithromycin. We may be familiar with the common, the Z-Pack. So that makes it easy for the patient to take and to dose. If the patient has a macrolide allergy, doxycycline is an option. We want to treat for a minimum of 5 days, and with the patient being afebrile for 2 to 3 days. Again, that Z-Pack is convenient because it comes as a 5-day treatment. Nice and easy dosing, easy to remember for the patient. So in our patients that have comorbidities or if they have risk of drug-resistant strep pneumo, that's when we're going to want to look at a respiratory fluoroquinolone, so moxifloxacin or levofloxacin. Moxifloxacin's a little easier to dose. You don't have to worry about renal dosing of the patient, but it can be a little bit more expensive. So again, insurance coverage may drive what product you're selecting for your patient. You can also use a beta-lactam plus a macrolide. So amoxicillin, moxicillin clavulanate, one of the cephalosporins, in addition to an azithromycin. A little more complicated, more pills for the patient to take. The respiratory fluoroquinolone would be a little better option if there's no contraindications. Doxycycline can also be used as an alternative to the macrolide. So similar to the patient without risk, we use the macrolide or the doxycycline. The patient with risk, we can use the macrolide or the doxycycline, but then we also have to add a beta-lactam. There's some parenteral, we can use ceftriaxone, IV or IM, or fluoroquinolones, but we want to really switch our patients to oral therapy as soon as they can tolerate. This will oftentimes happen if a patient goes into an urgent care. They may get a first dose IV and then get discharged on oral therapy. So when we're dealing with community-acquired pneumonia in pregnant women, the main pathogens are strep pneumo, H flu, and potentially viruses. For the macrolides, pregnancy category B, erythromycin and azithromycin, and pregnancy category C is clarithromycin. So again, azithromycin really could be our workhorse in the absence of contraindication. If there's comorbid conditions or recent antibiotics, that's when we want to add a beta-lactam plus the macrolide. So some common pediatric pathogens, again, strep pneumo, most common cause of all bacterial pneumonia in all ages. Infants, you can consider chlamydia. Again, these are going to be a little more rare. And then patients 5 years through adolescence, we want to consider the possibility of mycoplasma. Community-acquired MRSA is becoming more common, but again, not something that we're going to want to jump to right away. And there is a potential, again, for viral infection. So when we talk about antibiotic choices, in preschool-age children, so 4 or 5 years and younger, antibiotics typically aren't required. It's usually a viral infection. So really just watch and wait, symptomatic treatment. And then children greater than 5, slight typo on the slide here, that should be the other way. So greater than 5 years old, we're typically looking at bacterial pneumonia. We can use a beta-lactam, or if they have a penicillin allergy, clindamycin or a macrolide. Macrolides, if findings are compatible with CAP caused by atypical pathogens. In this case, you need a lab test to confirm. So again, you're going to need to do a culture at that point. But if the patient is not responding to the initial treatment, we might want to think about a culture and think about adding in a macrolide rather than the beta-lactam. As far as patient education for pneumonia, we want to tell our patients that it might be bacterial, viral, mycoplasmal. Education regarding the specific antibiotic prescribed, so we really want to make sure to talk about the disease state and also what we're using to treat the patient. Hydration, smoking cessation, and rest. Again, if the patient's has a lung infection, we certainly don't want them smoking. On top of that, as with any infectious disease, hydration is very important. And rest is also important because the patient could quickly lose their breath and not be able to reoxygenate very well. We should also tell the patients about symptoms of worsening status, right? So those patients that we want to return to us quickly because we may need to go to a second-line therapy. And in general, they should see clinical improvement in 2 to 3 days. So obviously this is a recording. There is not an opportunity to ask real-time live questions, but certainly in class and via email, we'll be happy to answer any questions you may have on this. Again, focus on some of the guidelines that were discussed, review the materials in the textbook, but really with things like this, we really want to go to the source. We want to go to the most current guidelines, so textbooks aren't going to be our best option. We want to review the text for learning about the disease state, because that's not going to change over time, but the pathogens may change and the recommended therapies may change. That's when we want to go to, cdc.gov/flu. We're going to want to look at the IDSA guidelines. And again, you don't need to memorize the guidelines of the algorithms, but certainly be familiar with them, understand, be able to recognize first-line treatments, second-line treatments, as well as inappropriate treatments and things that you should not be using